All right, welcome to our discussion on psychological disorders, abnormal psychology, and let's get into our first definition, which is what is normal. If you want to look at something abnormal, we got to know what normal is, and then also we have a better understanding of abnormal. Now, first, what we're going to do is we're going to talk about a book called the DSM, which stands for the Diagnostic and Statistical Manual of Mental Disorders. It's published by the American Psychiatric Association. And what this book is a listing of all the current recognized disorders and their symptoms. So it tells clinicians and therapists how to diagnose a particular disorder, what are the symptoms, and so on. Doesn't say anything about how to treat the disorder or anything like that. Just says, here are the symptoms, and if they've had it for, X amount of time, then and 7 out of any of these 10, or something like that, then you can give them the disorder or the diagnosis of having that disorder. So according to the DSM, what we call normal or abnormal? The first thing is, let's say if we're going to call something an abnormality, they have to meet this first criteria, which is they experience significant pain or distress and inability to work and play. Now that second part right there, I want to stop for a second and just say that the inability to work and play is a great, simple heuristic. Like it's sort of a way to sort of greatly simplify all of these. If you're trying to understand, does the person possibly have a disorder? One simple measurement is this: are they unable to work? Carry out their responsibilities? Are they and also are they unable to play? Or that is, things that once gave them pleasure and enjoyment in life, and like being with other people, socializing, doing activities they used to like. No, they're no longer able to do it, or they no longer want to do it. Right, that might be an indicator of a disorder. And then increased risk of death or loss of freedom. Okay, next, what might be considered abnormal is that if the source of the problem lies within the person due to biological factors, like they could have a trauma to the brain or some sort of insult to the brain, which is what clinicians say when they say insult to the brain. Could be a trauma, or it could be some sort of biological problem like tumor or something like that, or other things like too much or too little of a neurotransmitter, learning other mental processes. And last is that the behavior, the thought, the actions of the person and the mental processes is not a deliberate reaction to things like poverty, prejudice, or other conflicts with society. So, if the person's behavior meets these criteria, we may say that they have, they have a disorder. One important thing to mention is that someone is not considered having a mental disorder if their behavior, for example, bothers other people, right? Like, so if I do something that maybe you consider weird, or really weird, or maybe, like crazy behavior, that doesn't mean that I'm crazy. That doesn't mean that I have a disorder. It just means that it bothers you. So the APA does not, and the DSM does not recognize as a criteria for abnormality that the behavior bothers other people. It's not one of them. Okay, let's talk about some models of abnormality. And this would be ways of approaching what is normal and abnormal. Of course, from the medical perspective, disordered thoughts and so on are caused by some kind of issue with the brain, physical disease, trauma, neurotransmitter issues. And there was, although I should say, this is kind of an unusual view. I put this up here just because it's just so kind of out there and controversial. There's a famous psychiatrist in the 70s, um, and he wrote a book called The Myth of Mental Illness. And his basic position was, and so he's from the medical model, but he basically says that there's no such thing as mental illness, that it's a social construct that we've created to keep people who bother us, who make us feel uncomfortable. We give them a label and we put them, we house them in state hospitals to keep them out of our sight. Well, interesting view. Not too many people believe that. But it is interesting that it comes from a psychiatrist. And so I'll just put that out there just for you to contemplate. So again, I should mention it's a very minority view. I'm not too sure how many people beyond Dr. Zaz believe that. The psychological perspective says, as you can see, mental disorders are caused by your maladaptive way of perceiving the world, and also your past learning history. So the job of the therapist, and we'll talk about this when we get into the therapy section, is to identify those maladaptive ways of perceiving the world and then come up with new, more adaptive ways of seeing the world. Another perspective is the cultural perspective. And this is basically saying that what is normal is relative to the culture that you're in. And that actually is, a lot of people would agree with that. That what is normal in one culture, for example, like a way of greeting people in the U.S., we usually will probably shake hands. In other countries, it's not unusual for men and women to kiss and greet each other by kissing each other on the cheek and both cheeks. And that's really unusual. That's considered very abnormal if you try to do that here in the U.S. And so on. There's lots of other examples that I have listed up here, like eating disorders, primarily found in Western cultures. Koro, which is a thing found mostly in Japanese men, primarily in Japanese men. This is a fear of, in Japanese men, of the penis getting sucked up into the body. Very weird, from most other perspectives, but it's a phobia. Then amok is something that found in African villages, where the person basically, if we wanted to describe it here in the U.S., would say they snapped, or just went bonkers and started going on a murderous rampage. And that's what happens in these African cultures, some African cultures. So the person went amok, they run around with a machete and they chop up people and they do damage. Now, it's not to say that that's a normal thing, but it's they got a word for it. They have an explanation for it, right? And so on. And there's lots of examples. We'll talk more about that. Here's a little cover of the current DSM, which is the DSM-5. There's been many revisions over the years, starting back into the DSM started back in the early 1900s. And one famous example of a major revision was that it wasn't that long ago that homosexuality was considered a disorder, a mental disorder, surprisingly. And then it got revised and that was taken out. The DSM, I think, if I had to try to figure out, sort of average out them in terms of how many times it's been revised and how long takes it to be revised. It's about, I would guess, and don't quote me on this figure, but about every 15 years, 10 to 15 years, it takes for the DSMs to get revised. And this one just came out, the DSM-5. Okay. And you don't have to, of course, commit all these to memory, but this is just an example of, and this is from the DSM-4 actually, but they're basically pretty much the same. These categories of disorders. You have mood disorders, anxiety disorders, schizophrenia, dissociation, eating disorders, sleep disorders, adjustment disorders. Now, problem with diagnosing people, right at the top here, is that diagnoses are hard to remove, right? Once you get a diagnosis, hard to shake that. You know, when your people in your neighborhood, once they find out maybe that you once had manic depression, even though you were treated now and you have medication and you're no longer having those, you know, that suffering from that illness, and you're working just fine and you're functioning fine, people in your neighborhood say, "Oh, who's that? Who lives in that blue house down there in the corner?" "Oh, that's Joe, the manic depressive." Right? They just see you through that label, and it follows you around, unfortunately. And Rosenhan illustrated this as this fact that people see others through the label, by doing a simple experiment. He had a bunch of grad students and colleagues, and what they decided to do was they were going to fake being schizophrenic and get themselves admitted to a state hospital. And then, but once they got admitted, they were going to start acting normal. And the question is, how long does it take for the staff to realize, you know, and the physician there, to realize that these people are normal. There's nothing wrong with them. It took 19 days for the last person to get discharged out of all the people that got admitted. 19 days. And so what that tells us is great, study that demonstrates that point, that the staff and the physician were seeing their normal behavior through the lens of, this is a patient who is schizophrenic, and so even normal behavior is seen as symptomatic of schizophrenia. You know, for example, if they're sitting there taking notes on, sitting in their bed, taking their notes for their study, and say a nurse walking by will see that as, oh, that's that schizophrenic. They're being paranoid. They're writing down notes about other people. So that is unfortunately one problem with diagnosing and giving a label, which is what's hard to get around that. We kind of have to do that for lots of reasons, practical reasons. Also, it helps other physicians know what's going on with the client. If I give a label, then they'll say, oh, okay, now I know what's going on with this client, generally speaking. Criticism of the DSM, one is that it's unreliable. That's not true. In the beginning, it was true. When there was a lot more variability, but that was, decades and decades ago. Another criticism is that that clinicians have their sort of pet diagnoses, and so they, may not be perceiving their clients the right way, and so they'll just sort of, see and give everybody the same diagnosis, and that is a true criticism, unfortunately, but hopefully doesn't affect too many people. Or sorry, I shouldn't say it doesn't happen in too many instances. By far, most professional therapists understand try to be very objective and try to not introduce any of their own biases into their work. And for some reason, I can't remember the third criticism of the DSM. Let's see, it's reliable, it's valid, um, and we talked about the stereotype diagnoses, that pet diagnoses issue. What to think about that third criticism? Maybe get back to. Maybe for now we'll just say there's two criticisms. It's early in the morning when I'm taping this, so maybe that's why I haven't had enough caffeine in my brain yet. Okay, now let's talk about anxiety disorders. Now this is our first big group of disorders that we're going to talk about. Generalized anxiety disorder is sometimes called free-floating anxiety. It's not tied to any particular type of thing that you could be worried about. But it's this general feeling of unease. You're just worried, about, you just don't know what about. You're just kind of worried, tense. Like I said, free-floating. This person is the person who's kind of always sort of wound up, always kind of, they might be called the worrywart, right? They're the person who's just sort of always worrying. And actually, we say that generalized anxiety disorders happens in about between 3 and 5% of the population. It's a lot of people. And that might be a conservative estimate. Now, panic disorders. Person who has a panic disorder feels like they're having a heart attack. They feel like they're dying. They're short of breath. Their heart's racing. They're having really a lot of trouble, and they're feel like they're dying. So a lot of times, what happens though is they call the 911. They get in an ambulance. They get to the hospital, and the doctor doesn't find anything wrong with them. Right, by the time that they get there, maybe their symptoms have abated, and the doctors are, there's nothing physically wrong with you. And so we think that the generalized anxiety, the panic disorder is also quite underrepresented. It's happened a lot more than what the statistics show. What sets off panic disorders, we're not quite sure, although I think it's just, too much stress at that particular moment. And we will talk more about those when we talk about treatment. Now, phobias are basically irrational fears. The person knows that it's irrational. I know that it's irrational to be afraid of, I don't know. What would it be? Something like, getting on an airplane, let's say. Irrational fear. Right? So I think the statistics are it's like 1 in 11 million that any plane that you get on is going to crash. And you're way better odds of crashing and dying in a car, right? Just driving around in your car. I think just the odds for like getting hit by lightning or something like one in a million, right? So I mean, way better odds of getting on a plane, right? You're not gonna of not dying, but people have these fears, right? There's a fear, and people know that it's irrational. So what has happened is the person has learned that fear goes along with a particular stimulus or a particular situation. And they've just coupled that, and it's a really strong coupling. And the way that you break these down, there's a couple ways to break these down. And I'll just say when we talk about that in the therapy section. But I'll preview it by saying that phobias are perhaps the most curable of all of our disorders that we're going to talk about. Very curable, high success rate, like 85%, 95%. And so 2 types of phobias we'll just mention. One's the simple phobia, which is a fear of something particular, like fear of a doorknob, fear of a snake, fear of, the number 13. Then there's another type of phobia is called social phobias, where in the social phobia, you're afraid of a situation, like basically being evaluated by others, right? So a person may not want to go out into public They may be afraid of crowds. They may be afraid of going on stage, right? Public speaking. Another one is with social phobia is could be that they don't even want to write a check in front of someone at the supermarket because they're afraid that the cashier's judging them based on what kind of checks they have, their plane or their penmanship. They're being judged on their penmanship and so on, right? Again, we'll talk about how to treat those next time. Now, obsessive-compulsive disorder is, as the term implies, there's two things happening here, obsessions and compulsions. We'll start with the obsession, which is a recurrent unwanted thought. Like, let's say that I'm going to get, a recurrent unwanted thought is I'm going to get sick from germs, germs are going to get into my body, and it's going to make me sick. And that makes me anxious. That thought, just keeps coming back and back. So what am I going to do to get rid of the anxiety? I'm going to do a behavior to calm myself down, like washing my hands. Right? So the compulsion is the behavior that I do to calm myself down, to get rid of the anxiety that was brought about by the obsession. Right? So the compulsion is the behavior that you do in response to the obsession. So in this case, washing, and this, by the way, is one of the most common types of obsessive compulsions, is the fear of germs or contamination, and then the washing. So in extreme cases, people might find themselves washing their hands very vigorously for a long time, even to the point where and let's say dozens of times a day, maybe even into the hundreds in extreme cases, where their hands are bleeding, because they just are so vigorously scrubbing. That's obviously a problem. Now with OCD, here's some, just a quick listing. You don't have to write these down or anything. But so the top is the obsessions, like contamination, violent and sexual thoughts. That's another big one. Now the compulsions in response to these are washing, checking behavior, right? Checking to make sure something is done or turned off, like power's turned off to something. Counting cracks in the sidewalk or holes in the ceiling. Another interesting one is symmetry and precision. You gotta have things actually have to be perfectly the same. Like if you have a lamp on the end of one of the couch, you have to have the exact same lamp, positioned the same way on the other end of the couch. You can't just have one lamp. That's asymmetrical, right? You need to have a match. A person who would do this kind of behavior would, for example, straighten all their canned goods and make sure all the labels are facing forward. Straighten in their closets, like all the stuff that's hanging up on in their closet. Make sure that every hanger is 2 fingers apart or something like that, right? Symmetry works pretty well. This is a PET scan, Positron Emission Tomography, which measures the activity of the brain. What you do is you put some radioactive isotope in the brain, and it reacts with sugar. Sugar is one of the things that indicates the activity of the brain. And so you can see the red areas are the most active parts of the brain. And this is a very active brain, person who's OCD. Let's see. We're going to skip over some of this. We're not going to talk about post-traumatic stress disorder. I think your book might talk about it a little bit, but we're going to skip over that. And move into dissociative disorders. Now, here are some different types of dissociations. First of all, what is dissociation? It's just simply feeling like you've disconnected from reality a little bit. For example, one of the where is it? No, I wonder if I have it on here. These are some everyday examples, and some of these are a little weirder than others. Like Oh, suddenly realizing when you're listening to someone talk that you didn't hear part of what they said. That probably happens to a lot of us. Um, um, Feeling like you're looking at the world through a fog and people appear that appears unclear. That's kind of weird. Feeling like your body doesn't belong to you. But another one, I think maybe that most of us have had is let's say you get really absorbed in a book, reading a book on some weekend, and you're uninterrupted, maybe in your bedroom or something, and it's just a real page turner. It's just a really great book. And then what happens is after a while, maybe you have to go to the bathroom or you hear a loud noise or something disturbs you from your reading. Or maybe you just finish the book and you suddenly are aware now of your surroundings. And when you started the book, let's say it was 9 a.m. and now it's, let's say 7 p.m. or something. Something really, you just spent the whole day reading, right? Or whatever it is. And you'll get it's all dark outside. And wow, I just spend the whole day reading. But while you were reading, you were not really necessarily connected to reality around you. You weren't really engaged. And that's a mild example of dissociation. Now, there's different types of dissociative disorders. We have amnesia, which we'll talk about, something called fugue, and then dissociative identity disorder, which used to be called multiple personality disorder. So let's go back to amnesia. Now, with amnesia, there's a couple of different types of amnesia. I mean, most of us are familiar with from movies and TV. A person hits their head or something and they can't remember who they are. When you can't remember your past, that's called retrograde amnesia. But you're able to still make new memories. So you can't remember your past, but you can make new memories. Retrograde. But on the other hand, what happens if you can remember your past just fine, but now you can't make new memories? That's called anterograde, A-N-T-E-R-O, grade, amnesia. And both of these can be brought about by, a lot of times it's from an actual physical injury to the brain, but there can be other things that bring about amnesia as well. We'll talk a little bit more about how to treat those in a little bit. Now, fugue and DID are extremely rare. And if someone says, hey, I have this disorder, your first reaction should be, yeah, I'm not so sure. You should be quite skeptical because they're so rare. A fugue, as you can see on here, as the sudden unexpected travel where they they don't know who they are, and they actually assume a new identity. They kind of, when I say in lecture, is they leave their life. They just one day they go to work and maybe they just don't come home that day, and maybe they got a happy family life and kids and community involvement and no indicators that anything weird would happen. And so the poor family thinks the man or woman, whoever leaves, has been abducted or killed, or they just go missing, right? And what the person has done is literally just traveled away from their home, sometimes over to another state, far away, and they genuinely don't know who they are, and they take on a new identity, and they've literally forgotten their past life, and you start, maybe they'll get remarried, they have kids, and so it can happen. It has happened, but like I said, it's very rare. And to get a diagnosis of this, you have to have someone who is an expert in fugue, who knows it very, very well, and have them interview the person, and ideally have one or two more experts in fugue also identify or interview the person. And to the extent that they all agree, yes, this person has fugue, then we can say that the person has fugue. But you can't just have any psychologist or psychiatrist interview the person. They have to really be an expert in this disorder. And you would need more than one person. Oops, my disk is almost full here. Oh, it's not good. More than one person to give that diagnosis. Okay. Okay. Now, DID, multiple personality disorder, it used to be called. Presence of two or more identities. Behavior is controlled by the identities. Sometimes the identities don't know about each other, right? Amnesia, frequent memory gaps. Same thing here. Basically, what is happening here. By the way, I want to, before I go into that, what causes fugue? We think intense stress is going to cause a person, they feel like maybe they can't cope or whatever. Something snaps in their brain, for lack of a more scientific term, and they just leave their life. Same thing now with DID. What happens is, because so many times there's such a strong correlation with abuse, that we think that the brain, when the child, and usually this is childhood abuse, intense childhood abuse, the kid's brains can't cope with this intense abuse. What even adults can't. But they're still trying to. These are just very young brains, and so what we believe happens is the brain creates another identity that comes out when the actual abuse is happening, and that identity is strong. It's like a wall. It's like a shield, and that's the one that takes the abuse. Then it goes away when the actual abuse goes away, right? The actual act of the abuse. Until the next time, right? The next time the person is about to be abused, then that strong personality comes out again. And again, there can be more than one of these alternate personalities. Now, it's important to note that the kid, of course, is not thinking to themselves, I need to create another persona right now to come out to help me handle this abuser. Of course, they don't think that. It's just something that the brain does as sort of a defense mechanism. And just as a brief foreshadow, the way to treat this is to in therapy, do some intense therapy with the person and have them give up some of these alternate identities. They don't have to give up all of them, but get them down to a manageable few. To the extent that the main one, of course, is their core identity. And you can have a few on reserve, just sort of safety blankets, security blankets, that basically hopefully will never have to come out again. But it's not, the goal isn't to get it all down to one. It might be nice to get it down to one, but if you get it down to a manageable few, that's fine. Okay. Schizophrenia. Now, schizophrenia is marked by a detachment from reality, thoughts and thought disorders. Here are some major symptoms that pretty much in any kind, there's different types of schizophrenia, but pretty much no matter what type you have these kinds of symptoms, like your thoughts are disordered, your delusion, which would be a false belief, like a delusion of persecution, that people are out to get you. You could have a delusion of grandeur, which is that you're a super important person, like the Pope. You could have hallucinations, like auditory, like hearing voices. Tactile, which would be your skin, like you've got bugs on you all the time. Or, other types of hallucinations, smelling things, seeing things. The most common type of hallucination, I should say, is the auditory, hearing voices in your head. And usually they're very mean, and they tell you to do mean things. They tell you to, they sort of berate you. And delusions, most common delusion probably is the delusion of grandeur. I believe that and persecution, paranoid, right? We'll talk about that in a minute. Disturbance of affect. Here, what we mean is the person is either showing inappropriate affect, like they're crying when everybody else is laughing, or vice versa, or no affect, what we call flat affect, where they basically show no emotion ever. It's kind of a flat, neutral face. Now, bizarre behavior actually is fairly unusual and doesn't happen with schizophrenics, generally speaking. It's a real small percentage of schizophrenics will show bizarre behavior. So, interestingly, most of the time, just looking at someone, you can't tell if they have schizophrenia. Here are the different types of schizophrenics. You should, for this, maybe just write down or note the 5 types and maybe just a couple words about what defines each. So you have disorganized, lots of different types of things going on there. Catatonic is one that's interesting. We haven't really talked about this yet. And it says bizarre physical movements, but one of the most interesting is this motionless stupor. The emotional stupor is what psychiatrists, psychologists call waxy flexibility. Where if you get a catatonic schizophrenic, you can go up to them and you can move their body around like they were a doll. And the weird thing is they keep the position of their limbs, the way you position it, for hours and hours. So if they're sitting there, let's say, and you lift up their left arm, right? So it's sort of like perpendicular to their body. You're just stretching their left arm out. And then you let go. It will not fall down to their side. It'll stay out for hours and hours and hours. Right? Weird. Doesn't happen in any other types of schizophrenics. Paranoid schizophrenic, as you can see, is, and I should say that this is the most common type of schizophrenia, paranoid. Delusions of grandeur, delusions of persecution. Undifferentiated, as you can see here, lots of different, sort of a mishmash of all kinds of different symptoms. And the last one is residual, showing sort of minor symptoms of schizophrenia after a serious episode. I should say there's something interesting also to note about schizophrenia, and that is how fast it comes on the person. It has big implications for whether or not it's going to be serious or treatable. Something that has chronic onset, which means that it takes a long time for the person to develop schizophrenia. It happened over months, maybe even a couple years. Very poor prognosis for chronic onset. Acute onset, like let's say it comes on the person in a matter of days or just a couple weeks. Actually, they have a much better prognosis for actually getting rid of schizophrenia. So it's something to be aware of. Here's a CAT scan of 2 different brains. The brain on the left is the normal. You can see how full it is, small ventricle in the middle. And on the right is the schizophrenic brain. Huge area right there on the outer part there, that black is just fluid. The brain is a lot smaller. The ventricle areas in the middle are bigger. And you can see the fissures, the little wavy little parts all around the brain are wider. They're not as thick. One of the interesting things that we're not sure of is what the sort of chicken and the egg question. Is it the case that schizophrenia causes the brain to shrink, or is it the case that this kind of brain causes the person to have schizophrenia? Here's the PET scans of controls versus schizophrenics. You can see how the so-called normal brains are much more active than the schizophrenics. Here's a little graph about the types of hallucinations. As I mentioned earlier, auditory, most common in schizophrenia. Genetics of schizophrenia. Let's go all the way down to the bottom. Identical twin shares the same genetics as you do. They have schizophrenia. You now have one in two chance, right? 50% that you will also develop schizophrenia. Also, if you're an offspring of two parents with schizophrenia, also probably a 1 in 2 chance. But look what happens if your fraternal twin gets schizophrenia. Look at that. Drops down to something like 17%, maybe. So the genetics plays a part, and sometimes a strong part, but also your environment plays a big part too. Let's talk about major depression, and we're going to talk about dysthymia and bipolar. We're not going to talk about cyclothymic. Major depression is really clinical depression, type of depression that can get you admitted to the hospital. Person thinks about suicide. They feel like they're not able to go on. They just can't function, right? Trouble sleeping, lots of different symptoms. Feeling hopeless and helpless. So this is not the blues. This is really heavy-duty, major clinical level depression you kind of get admitted to a hospital for. Now, contrast this with dysthymia, which is, it says, chronic low-grade depressed feelings that are not severe enough to qualify as major depression. So you might say this is the blues, right? Person's feeling sad, but they're still able to work and play, right? Or they're still at least able to work and get through their daily responsibilities. Now, bipolar is what we call manic depression. So you have one or more mania episodes, which is this incredible high feeling of euphoria, and then you'll cycle down to a major depression. So you're going from the highest highs to the lowest lows. It's this tremendous roller coaster. And sometimes you can switch within a day. Boom. Interesting thing about, so bipolar, the way to treat this is with lithium for mania, and then antidepressants for the depression, and also talk therapy. Now, one of the interesting and sort of scary things about bipolar versus major depression is, of the two, suicide is more likely to happen in bipolars. And the simple reason is, if you're in major depression, you're feeling like you want to kill yourself, the actual thought of, okay, well, how am I going to kill myself? Any of that, I have to get this, I have to do that. That requires work, right? You have to get up, get these things, and the person literally doesn't have any energy or doesn't want to, I just can't even, they're not even motivated to do that. But the scary part comes in, for example, let's say you're having those thoughts, suicide, right? And you're in a bipolar disorder. You're in this major depression port. Now, let's say you're cycling up, right? You're going up toward mania, and you're getting more and more energy, more and more energy. Somewhere in that middle part, not quite manic, but you're between manic and depressed, you will suddenly now have enough energy to carry out your suicidal thoughts, and that's where the suicides actually do happen. Quite dangerous. Here's an example of someone with bipolar disorder, depressed, right on the 17th of May. Look at that, basically no activity almost. There's really a lack of activity. Manic, look at that, boom, huge activity. And then a little later, the 27th, from the 18th to the 27th, we don't know when the shift happened, but they're back to their depressed state. Okay, I hope you enjoyed our discussion on abnormal psych, and I will see you next time with therapy.